Thank you, Pam. And so my task now is to take this body of work and talk about how it might influence Social Security policy and the relevance for Social Security policy. And I have to say the authors really gave me a lot to work with. She's to be commended that she did this in 15 minutes because there are about 11 tables in the paper and there is a lot of work done here. So it is my pleasure to comment on this paper. So I start off with what's the motivation behind this, and I suspect I'm preaching to the choir in this room, so I can go relatively quickly about who cares and the policy relevance of predicting retirement ages, solvency, sustainability, given the role of health. But just to very quickly summarize, based on Social Security fact sheets for 2017, our life expectancy is growing. We're up to about 85 on average for men and women, but people are still retiring at an average age of about 63. So close to what it was decades ago, and yet we're living a lot longer, and we're living with a lot more problems, and that's going to be costly for us through the Medicare system. So we're trying to get people to work longer if they can work longer, and that's a big question, the if. So what is the role of health, and how does it impact work? Very important for Social Security policy, a question that we have been asking for a very long time. So understanding the role of health on retirement has long been recognized as an important factor in setting optimal Social Security policies aimed at solvency while protecting beneficiary well-being. Policies that use financial incentives to promote a longer work life may not realize their desired outcomes if health factors dominate the financial incentives. Increasing the early age of retirement is one such policy that provides a financial incentive for increasing work life among older workers. At the margin, we should see an increase in work life years. Health is a significant predictor of retirement before the normal age. How much of this apparent health motive is in fact driven by preferences combined with existing financial incentives for earlier retirement is difficult to assess for the reasons that the authors give in the paper. She didn't talk about it all that much, but the difficulty with the simultaneity of health and work. If workers in poor health are unwilling or unable to work beyond the current early age of 62, they may seek alternatives like the Social Security disability insurance for earlier retirement, rendering the policy reform less effective than desired or even inefficient. Policies that penalize earlier retirement may also pose undue burden on those too sick to remain in the labor force longer, particularly given working class individuals may be more likely to have physical limitations in physically demanding occupations. Therefore, understanding the independent effect of poor health on the propensity for work among older people, separately from ability and willingness to pay for leisure, is critical in policy design. So I'm going to elaborate on these points, but the main purpose of this work is to uncover the propensity for work among a healthy population of older workers based on expectations about future health as well as preferences for work under given hypothetical scenarios of future health and given existing wealth status. This ability to observe it counterfactual is a real contribution to the literature, really speaks to using experimental design to get at preferences, to be able to control for them, and then really better predict policy. So what is the merit of this potential contribution? Again, the understanding, given how simultaneous the two are, health and work, is to perform sensitivity analysis. While any individual study suffers from unrealistic assumptions necessary for identifying relationships, the combined vast literature relaxes and imposes diverse assumptions, allowing for sensitivity analysis, which eventually leads to robust findings. What is novel in this work is the direct measurement of preferences under hypothetical health states, which reveals counterfactuals in health states given preferences for work and wealth. The authors are able to relax assumptions surrounding endogenous self-reported health and capture contingency planning, which may be free from justification bias. Responses to hypotheticals will still vary by observable factors like wealth. Given we seek to understand how people will behave when sick, rather than how they would prefer to behave when sick if they had no financial constraints, the findings are important for predicting actual policy outcomes. Success hinges on the absence of reporting bias in the hypotheticals. So my first comment is going to be about sample selection. The sample selected are those who are less well off in this vanguard VRI population. So in other words, may respond to financial incentives more. Those who are left out are the richest and may also be the healthiest. I am taking the author's word for this because they did not report summary statistics for those omitted from the analysis. I would want to see them to rule out sample selection bias, which could be significant in a study on work-life duration. So we need a comparison of those attributes between those included and those excluded. They could be richer and they could also be sicker, but those things are relevant for this policy question. The authors say in their paper, this sample therefore represents a subpopulation of particular interest for our analysis, as it is made of individuals who in principle have the capacity to work longer, but for whom assessing the causal link between health and retirement is particularly challenging, as they have not experienced the health shocks used for identification in the standard approach. So basically the authors are saying this is the sample we want to look at. I would just like to be convinced of that by seeing who is left out. A majority of those omitted from the analysis also have the capacity to work longer physically, but are able to afford earlier retirement. I'm speculating because I haven't seen it, but I suspect this might be true. In other words, we may also not be able to identify the impact of health on retirement decisions, given those omitted wealthier individuals have not experienced a shock. The difference is that they have retired early despite good health and therefore are driven by a wealth effect. Those who remain either have a higher propensity for work due to preferences or are less able to afford retirement leisure. It is important to know the study sample and the population they represent. It may be that those who retire early, whether primarily due to wealth or health, would retire early regardless of policy. We can say that for the healthy and wealthy. But it is not clear that there are not some omitted from the analysis because of poor health that would still be working under different policy circumstances. I'm actually looking at the time and realizing I'm spending too much time motivating that we need to see who is excluded from the sample because it could affect the results. So just keep in mind that we're interpreting it based on a potentially non-random sample of people who are different in health and wealth. If you think in terms of a two-period model, so I'm just thinking if the authors add just a little bit of structure in terms of a two-period model, because I think that would fit this scenario quite well. It omits those who are older and have already experienced the poor health outcome in period 2 and chosen retirement, and those who are well off enough to retire regardless of health status in period 2. So thinking about it this way, we might get a sense of where people are at in the decision horizon and who we include and who we don't. It just might help us to think about the transition probabilities that we're seeking to measure and those that we do measure, because we are basically measuring transition probabilities. So what are the policy implications? That's really the primary purpose of my task, of focusing in on this select subgroup. If the findings are such that this above average class works despite poor health, is that a rationale to keep the retirement age as is? So I'm trying to speak to the policies that are relevant, i.e. we would allow the more vulnerable populations who may have greater difficulty working with health conditions the early out option, given those with more secure and less physical occupations will opt to keep working. So in other words, this work may motivate not increasing the early retirement age. If you find the responses to health decline are significant in this population and negative, then what? You may have to lengthen the early retirement age to incentivize longer work lives, but that may result in a loss of social welfare. If poor health drives people out of the workforce sooner, the solution may be to improve health. That's always the solution, and we know that technology is helping us in that direction. But how can we learn that from this select sample, and why is it more interesting for them? Just something for the authors to think about. And then the bridge job choice. So they include in their analysis those who are in bridge jobs. Is it possible that those who are in bridge jobs made that choice because of health problems? So the significance of the findings for policy, I'm concluding now and I have 30 seconds left. Innovative approach to uncovering treatment effects or individual level health effects on work and aggregate them to the population parameters. I'm gonna skip to the next slide, which summarizes all of the results again, and I think that's a good way to conclude because they do have so many findings. So let's just do the key punchlines for policy. And this is, I went through every table and took the key punchlines as I saw them. People are optimistic about future health outcomes, and the variation is predictable by age and SES. Health does drive earlier retirement on average. The response to poor health is significant. Self-reported future work propensity is influenced heavily by age when health is omitted. So I'm looking at the specific results and showing where she can make some of the claims she makes, and she is able to make them. It's sensitive to the interaction with health. I'm not so clear in Table 5 how that would predict causality. I will give the authors my comments after this. And when examining counterfactuals for the true treatment effects, the authors subtract. I also did another calculation that I thought might be interesting for policy. Going from good health to poor health, the decline in the impact on work is 68%, a 68% reduction, in work, and for 4 years, 78% reduction. So those are pretty big transition probabilities from going from good health to poor health. And I think I'm right on time.
You are just about on time. Thank you very much, Sam.